of the webinar, and we thank everyone for taking the time to join us. I have the following people indicated on the line. I'd like to welcome each one of you: Aaron Baer, Al Aparicio, Brad Halverson, Adeline Middleton, Linda Caples, Michael Schoen, Ramila Kostick, Paul Mazmanian, Stephanie Armstrong, Suzanne Zimnick, Tom Van Hoof, Vicki Kekatoff, Wendy Murphy, and William Defoe. And others will likely be joining. We also have Jim Ranieri and our presenter, Dr. Curtis Olson. Before we get started, we'd just like to remind everyone that if you're having audio difficulty, may get better reception using your telephone rather than the internet. I will be muting everyone when Dr. Olson begins his presentation, and if you do have a question, please raise your hand, and then we will unmute you at the appropriate time. I'd also like to remind you that we will be recording the presentation today and the discussion, and these will be available on the website. Also, for those of you who may not have done it yet, the articles are posted, and you can access them through the emails that you received or through the website. So without further ado, I would like to introduce our speaker today, who really needs no further introduction. Dr. Curtis Olson is currently at the Dartmouth-Hitchcock Medical Center as the Director of Research and Evaluation. He has a doctorate in adult and continuing education from the University of Wisconsin-Madison, and has been involved in healthcare professional education for more than 20 years. Before coming to Dartmouth, he was the head of research and development in the Office of Continuing Professional Development in Medicine and Public Health at the University of Wisconsin, where he directed an interprofessional team charged with developing the next generation of program planning and evaluation practices. Personal research agenda focuses on understanding how clinical teams learn and change their practice, and how that information can be used to develop continuing education. Also, very importantly, he is the editor-in-chief of the Journal of Continuing Education in the Health Professions. So I'd like to welcome Dr. Olson, and at this time I will be muting everyone. And again, if you have questions.
Thank you very much, Barbara. Just a couple comments before I get started. I really want to encourage everyone to ask questions and offer comments as we go along. We'd like to make this as participative as possible, as much as the technology allows. So as Barbara mentioned, as we go along, if you want to speak up, if you have something to contribute, raise your hand. You can also send a question, for example, that you'd like to have answered via chat. Barbara will be monitoring those, but we'd like to hear from you. So I do think that the quality of the session will rest on the extent to which you are all actively participating. I'm prepared to fill the hour if necessary, but I think it will be much better if there's an active conversation. So one other thing, I'm going to give more attention to the Roberts article and the Atwood piece that was listed as sort of an optional reading. Davis, unfortunately, I was unable to get permission to distribute that one. And I'm going to be paying somewhat less attention to Eva and Reguer, not by design, just the way it worked out. So if you see opportunities to bring in perspectives from that article, the Eva and Reguer article, please do so. Why this particular topic? two authors, Daniel Duffy, and could we go on to slide number 2, Jim, please? Daniel Duffy and Eric Hombo wrote a reaction to the piece that Dave Davis did, Paul Mesmian and others, reviewing the accuracy of self-assessment. And they did a really nice job, I think, of highlighting why we're interested in this as a field. As continuing educators, we rely on self-assessment to determine learning and improvement needs. It's an important input. The logic is better self-assessment means that there's better identification of needs, and at the individual level, increased motivation to learn, presumably, and ultimately patient care. So it really occupies a critical role in our practice. In addition, they point out that ineffective self-assessment is effectively a loss of a motivator. So it can, without an accurate understanding of where our needs are, where our strengths and weaknesses lie, there's we're not likely to be as motivated to do something. And finally, when we discover gaps on our own, they tend to be more salient rather than having somebody else point them out to us. So there are a number of reasons why this is important. Next slide, please. So I would like to start out by posing these two questions to all of you listening. Just to sort of get us thinking more concretely about what we mean by physician self-assessment. So what are some examples, and in particular, what kinds of self-assessments do you ask of participants in your educational programs? So if you would please raise your hand.
Linda? You can go ahead, Linda. Linda, I think you might be self-muted. Linda, I think if you could just unmute your line.
Oh, there we go. How's that? Okay. So at MCW, one of the things that we do, particularly in neurology, is just basically follow their maintenance certification Part 2 self-assessment process, where they need to go through, multiple choice questions with substantive feedback before engaging in the CME activity, and then we can use that data to help guide the development of that activity.
Mm-hmm. Very good. So that's a fairly highly structured way for clinicians to assess themselves.
Tom, I think you have a comment, and you should be unmuted now.
Yes, thank you. And so, so for me, the study raised an issue in the distinction, at least in my mind, between self-rating and self-assessment. I guess without thinking about a lot, I think I've lumped them together. And so, so for me, the article was very helpful just in raising the distinction. And so the study, I think, makes clear this distinction, or at least it certainly spells out what self-assessment means, and they describe it as collecting, interpreting, assimilating, and responding to information from multiple sources. And I like that, I guess that description or definition. It's often in quality improvement and in continuing education, we provide clinicians with another perspective, typically either using claims data, through performance measurement and feedback, it's not often that we're able to provide multiple perspectives. And so I guess depending on how one defines self-assessment, we may or may not be doing much or kind of asking clinicians to do a lot of self-assessment.
Yep. And the definitional issue is a key one. So, I mean, in my the rhetorical question that I posed in the title, are physicians really so bad at self-assessment? The argument will be, in effect, it all hangs on what you mean by self-assessment, and so that's a very important point.
William?
Yes, hi. I think one of the ways that we try to get some self-assessment with, say, a group of family physicians is to ask them what is their perception as to how many or what percentage of their patients kind of meet the guidelines, whether it be for blood pressure control or diabetic management. And it's often, of course, quite surprising when the physicians are given the hard data from the EMR search, et cetera. So I think, what we've seen is there's often quite a disparity between what their perceptions are and when they're actually presented with that data.
Yeah. And that's a very interesting example. There is an implied question behind that. If you ask what percentage of their patients meet the guidelines, the question that lies behind that is how many of them should be meeting the guidelines, and how do you feel about the whatever gap you see between those two numbers. Yes, another nice example of self-assessment. Well, thank you for those examples. Can we move to the next slide, Jim? Sticking with Duffy and Holmbo for a moment, they made a distinction that's similar to the one that Tom was making between two types of evaluation, self-assessment. One they called self-evaluation, which they saw as the type of assessment that was being addressed in the review of the literature, the systematic review that Davis et al. Did, which they described as something similar to the example we were just provided with what percentage of your patients. It's a largely unstructured ballparking kind of guesswork estimate. It's called different things: self-rating, self-audit in a very broad sense. One of my favorite descriptors for this is the "what's my grade" approach. And so, would I give myself an A, B, C, or how would I assess myself in this area? They contrast this with the example of precisely of the type that Linda Caples provided, and that is a much more structured, guided self-audit. So it's more systematic. Very importantly, it uses data rather than just your global assessment, your sense of how things are at. It may very well be self-administered, and so in that sense, it is very much a self-assessment. But there's some kind of scaffolding or structure that helps you to do things like take a look at your work products. What MOC does that, for example, asking clinicians to take a look at a certain number of charts and to stand back and look at their performance, or it might be test results. Again, like in the example that Linda gave. This was about the best that I could do in finding any type of a broad, encompassing typology. There are others, such as Kevin Neva and Glenn Regehr and Joan Sargent, who have thought about exactly what self-assessment means and what it is and what it isn't. And but this is an area that, at least with the literature that I'm familiar with, and this is by no means something that I'm completely up to date on. I mean, I think there is, this is a need. There's a gap here for a framework, a conceptual framework, if you will, for helping us really sort out some of these fine distinctions between different types of self-assessment and do so in a comprehensive way. Because as we'll get more into later, some of those distinctions are critically important.
I think
yes.
Tom had a comment.
Go ahead, Tom.
Hey, Kurt, this is Tom. Just wondering how important the purpose of the self-assessment, or in the case of when one's seeking feedback from multiple parties, how important the purpose is for the self-assessment. For example, is it part of a high stakes determination? That might drive payment or certification or licensure, or is it, more formative, for the purpose of, educational purposes or internal quality improvement purposes? I'm just wondering your opinion and others about, I guess, how important the purpose of self-assessment or the, the intentions of the use of the data might be to, I guess, the accuracy or effectiveness of it.
Well, why don't we turn that question over to the group?
Linda?
Well, I think that's a very good question, and I think it serves to the motivation for a particular individual to, take it, seriously, more or less seriously. If it's, tied to reimbursement in some sort, they're obviously going to be a little more motivated to maybe not necessarily engage in the self-assessment, but to address the issues that have been identified in that assessment. Versus doing some type of self-assessment to inform a grand round series or something like that.
Mm-hmm.
So, yeah, I think it just definitely serves towards motivation. Now, in terms of like with neurology and maintenance of certification Part 2 self-assessment, or working with our pathologist in Part 2, yes, that's for board certification or to maintain their board certification, but they're not particularly highly motivated. It's just another checkbox that they feel they have to go through in order to maintain. They don't, the weight or the gravity of it does not have as much of a profound impact as, one would assume.
Mm-hmm. So thank you for that. And I mean, my sense also is that the conditions, whether it is mandatory or elective or somewhere in between, is significant. I think how what we know about, in terms of general principles of adult learning, things that are driven by the needs and interests of the learner oftentimes are more effective. So you raise an excellent point. What I'd like to do is to put a question in front of you, and Jim, can we put up the poll at this point? So what I want to do is pose a self-assessment question to all of you. This relates to a self-evaluation. This is obviously an educator-type competency. How would you rate your effectiveness on the following? Designing effective PowerPoint slides. So give everyone a few minutes to weigh in on that. what I want to ask you about in a moment is your thought process, how you went about answering this question. Okay, it looks like nearly everybody has voted. Jim, why don't we close it there and show the results? Okay, so roughly a quarter said fair, half good, and then the rest either very good or excellent. Very good, thank you for that. Now, Jim, can we move on to the next slide, please? So what I want to do is think about how you came to decide your answer to that question in this framework. For me, this is a nice illustration of the basic elements of any assessment, any evaluation, including self-assessment. So, the key elements here are the tree, which is the thing that is being evaluated, the post, the poll, if you will, is the standard, the what should be, and so the implication here is that trees should be straight, and so the gap in between indicates, well, we all know gaps. The gap between what should be and what is. The role of obviously some kind of an intervention to bring the two together. Now, as you think about how you decided the answer to that question about your designing PowerPoint slides, to what extent did any of these things, how did you think about these things? Were you thinking about in detail about what the tree looked like for you, what your slides look like? What were you thinking about in terms of referencing that against any type of a standard or assessing that? I mean, what was going through your mind?
Jack? Jack?
Hello, everybody. This is Jack. Hey, I immediately thought of, well, what is the ruler that I should be using? And I remember that there should be 6 lines per slide and 6 words per line that go back for many years. And then said, okay, I guess that's what I do. So it was a very superficial remembering some key points that happened to be easy to remember.
Mm-hmm. But nevertheless, there was at least one very concrete criterion that came to mind for you. Mm-hmm. Someone else want to weigh in on this?
Linda?
This is Linda. Hi, Jack. For me, I thought of the actual classes that I had to take on how to develop PowerPoint, the volume of PowerPoint presentations that I produced, the responses of students or colleagues to the data that I presented, and the number of PowerPoints that I look at that other people have created.
Mm-hmm. Mm-hmm.
And Bob has a comment also? Bob?
Hi, am I on?
You're on. We can all hear you.
This is the first time I've used this microphone. Yeah, hi, Bob Morrow. How are you all? Well, I have a somewhat contrarian view, which I'm sure is no surprise. I looked at the tree and thought back to the slides and said, how do you yoke your idea to a standard so that everybody's doing the same thing, which is kind of an industrial approach to education. And the tree might not want to be where it is tied up to a stake, and it might be the wrong stake, and there might be a wave coming that the tree would have been able to manage better if it was not tied up, and so on. And the concept of how good are you at PowerPoint comes down to, do you think PowerPoint is an effective way to communicate, or is it an effective way of stifling communications and structuring the talk so that it can't be interrupted? And I'm not good at that.
So very good. So what I hear in your comments, Bob, was questioning the question, so to speak. I also heard that there was perhaps a different kind of standard operating for you, and that maybe goes to the effectiveness part of the question, and that is, should the standard be hewing to some guideline, of which there are many, many of which are evidence-based in terms of effective communication using resources like slides, or is that less important than, is it working? Does it serve the purpose? It may not be technically correct, but they're but nevertheless effective anyway. So, which brings us to the third. Well, I mentioned there was a value judgment implicit in the post here that says the trees should be straight. And there's another one here that is more of the global assessment piece. And that is, as you look at the gap, as you think about the gap between the way that you design PowerPoint slides and whatever standards that you're aware of for what they should look like, it's whatever gap you find, good, bad, or otherwise. And so that's another difficult, sometimes, judgment to make, especially if you are trying to get two raters, yourself and an other, to come to some agreement about what this is all about. So part of what this is intended to highlight are some of the challenges, the places where comparisons, ratings from different raters can go astray. So you may disagree on a tree, you may disagree on what is the performance. You may have less than full knowledge of what the performance is if you're rating somebody else. What is the benchmark? There may be disagreements over what is desired in terms of practice, if that's the focus. And the disagreements, if you're asked to say good, bad, or otherwise, what is the significance of any gaps that you find? So, I mean, this is a process that is fraught with lots of potential challenges. Well, Jim, can we go to the next slide, please? So what I want to do briefly is, I won't do justice to this in just a few slides, but thinking about reviewing some of the main findings from the data set I'll review of the literature. This is a systematic review looking at accuracy of self-assessments and observed measures of competence. So some other external measure that might be a patient satisfaction questionnaire. It might be a test of performance of some kind, either a true-false test, an oral exam, or a simulation, the assessment of a standardized patient, and so on. So they looked at 17 studies that met their criteria, and there were 20 comparisons made in those. And so some of the main findings, as a group, physicians as a group, and across multiple assessment tasks, the physicians are generally not very good at self-assessment was the finding, and I say many others there because this is a finding that has been demonstrated in other professions and areas as well. Very concerningly, those who are the least competent are the most inaccurate because they tend to overestimate their competence. On to the next slide, please, Jim. But what caught my attention and what the investigators noted was that there is a high level of variability across studies. And so of the 20 comparisons that they looked at, 13 of them show little or no or inverse relationship between the self-assessment and other measured. But there were 7 that showed positive associations, and 3 of those 7 showed, and this is a quote, consistency and little variability between self-ratings and other performance measures. This struck me a bit like studies of the effectiveness of different educational interventions. We know that some are more or less effective than others, so that academic detailing will be, on balance, will be more effective than just, say, a straight didactic presentation in terms of changing practice. But when we look at what's going on within those studies, there's huge variability, and that is some ways of doing academic detailing will be much more effective than others, even within a same study. For some learners or some sites, it will be more effective than others. So there's a lot of variation in there, and we don't understand that very well. We don't know what is influencing those kinds of differences, and so and given the importance of self-assessment, I think this is a really critical question to try and understand better why that variability is there.
And Kurt, I think Tom Van Hoof has a comment. Tom, you may want to unmute your line.
Yes, Kurt. So what you just said resonated with the comment in the study, and they were describing how well their models, I guess, predicted or explained the variance, and it's kind of humbling, even with well-performing models in general, particularly relating to effectiveness of educational interventions, how little the models actually predict, and then it further supports, I think, the speculation that the contextual variables, may have much more to do with effectiveness and impact than do, I guess, some of the interventions we're using. So I think all the more reason for the importance of having multiple sources of data to understand the context, in which one's operating.
Right. And I completely agree. I mean, these are, whether we're talking about interventions or self-assessment, these are very complex phenomena that are influenced by a lot of different factors. And so, yeah, and that's part of what makes it particularly interesting, I think. Next slide. So what I took away from the study was that some physicians can assess well in some areas, some of the time, but the ability to do that is not a trait. So this is not something that you're either good at or bad at, but it varies with the context. And even when physicians as a group aren't doing well, there's variability. Some are doing well. Others are doing abysmally. And finally, our understanding of factors is limited. Next slide, Jim. So this is where multi-source feedback comes in. Given the inaccuracy of the unreliability and inaccuracy of our self-assessments, and I say our because this seems to be a human issue with human beings, not just with physicians alone. This is seen as one way of doing better at those assessments. Has a long history of use in the business world. It's becoming more widely used as physicians. It's typically a survey of peers or members of the clinical team or patients. It will often include a self-assessment. And the rationale behind this is that because we're not very good at self-assessing, if we can get anonymous feedback, it's not always anonymous, but often, usually, from others, it should help us to see how others see us and also identify areas where change is needed. And again, this is in terms of the study. Next slide, please. The Roberts study. This is an attempt to tease out what factors contribute to variations in self-other agreement. So the reasons that the authors said that this was of concern to them was, number one, that disagreement may reduce the likelihood that negative information will be acted upon. One of the reasons that it's theorized that we are bad at self-assessing is that we tend to filter out information, especially negative information, that is not consistent with our view of ourselves. And so any disagreement, especially in negative information, can be a problem. And this one, the next one is agreement is positively associated with aspects of job performance. And they gave the example of effectiveness and leadership. And they actually cited a study that we're going to look more closely at in a few minutes here. This is the critical link, isn't it? Because it's not, what we're really concerned, this sort of goes back to the point that I think Bob was making when we're talking about PowerPoint slides, that in the end, isn't it all about performance and effectiveness? And so this is really the critical issue. The whole idea of self-assessment or multi-source feedback is aimed at improving performance. Next slide, Jim. So they wanted to identify factors that are associated with variation and self-other agreement, and the cause of the difference. It's very interesting what they did. When there is a difference, is it because the physicians are high and the patients are low, or vice versa? What's going on? Next slide. So the subjects were physicians in 11 hospitals in the UK, a very large number of patients and colleagues who are involved in this, providing information on 1,000 physicians. This was an existing data set. They were doing a secondary analysis. The instruments that they were using, patient ratings came from a patient questionnaire, colleague ratings from a colleague questionnaire, and then there was a self-questionnaire that was sort of where physicians did both. They did some version of the patient questionnaire on themselves, some version of the colleague. So there was opportunity here for fairly direct comparisons. And they set a minimum in terms of the number of surveys that needed to be performed, the number of ratings in order to do this. Next slide, Jim. Sorry, my computer has gone to sleep. Very good. So these are some of the items from the patient questionnaire which were not included in the article. You had to go back to something that was cited by these authors. There were several items, I forget how many, on the order of 15, 17, something like that. These are representative. So, to what extent is your physician good at being polite, making you feel at ease in his or her presence, listening to you, and so on. And the scale was poor to very good. So this is of that, that global assessment. This is the self-evaluation kind of self-assessment. This is not the MOC Part 2 type structured assessment. Next slide. Similar kinds of items for the colleague questionnaire. So same scale, different focus, very broad categories, clinical knowledge, diagnosis, clinical decisions. These are really high-level, global kinds of assessments. Next slide. So they didn't actually, neither article had any information, detailed information about the self-PQ and the self-CQ, but presumably there was something like, instead of the patient form, which says, assessing your condition, it would be something like assessing your patient's condition. Next slide. So they looked at the magnitude and the direction of the discrepancy scores. So, were physicians overrating and underrating, and how much? So to do that, they took the self score, they subtracted the other score, and came up with an agreement score. So if it was negative, they underrated themselves. If it was positive, they had overrated. Next slide. They also collected well, I won't say they collected. Because this is an existing data set, they had a predefined set of demographics available to them. This is one of the challenges with this particular study, because ordinarily you would choose information like this because you have an hypothesis that says that you expect results to vary based on these factors. And you come to that hypothesis in reference to previous studies, the theoretical literature, and so on. So, for example, previous studies that say that there is gender, some theory that says age should have an important impact here, which lends not only lends strength to the study, but helps you interpret the results because you have a framework. But they unfortunately didn't have the advantage of that. Next slide. So what they found was when they looked at the two ratings from the physician, the patient questionnaire and the colleague questionnaire, they were strongly correlated, but that was about all that was correlated very well. Neither of those was correlated with how the patients rated the physician or how colleagues rated them. There was some weak but positive correlation between the patient questionnaire and the colleague version, and most physicians underrated themselves. Now, the next slide, Jim. They also found that doctors trained in the UK underrated themselves more severely than others. This sort of highlights some issues around looking at discrepancy, the degree of agreement, because they underrated themselves greater, the gap was larger, but they were evaluated in much the same way that that the other physicians were. So even though the comparators were similar, that their discrepancy was larger. And here's an interesting one, that when they looked at the number of younger and older patients that returned surveys, which presumably were representative to some degree of the population that the physician was seeing, that the discrepancy increased due to lower self-assessments on the part of the physician. So they thought they were less effective, they were less good on these criteria. Now I'm curious, what ideas do you have about why this might be the case?
Bob Morrow?
I know in my world of seeing patients, people I know well, I have a very good sense when they're a better sense of when they are not doing as well as I'd like or as they would like. Whereas people who are from quite different cultural backgrounds I don't know very well will frequently try to please me by saying they're doing the right thing. And so I'll have a more profound sense of failure with the people I know well.
Mm-hmm.
And Mila?
Well, I just thought that maybe very young people and not very old, but older people are less critical, and that may have contributed. So, or tend to be more generous in ratings.
Well, what they're saying is that the ratings from younger and older patients were much the same as they were for all patients. But what was happening is that as those percentages went up, it wasn't that their ratings changed, but the more it went up, the lower that physicians were self-assessing. So, well, this is precisely the point about what happens when you're looking at demographic information without some kind of a theoretical base behind it. So it's very difficult. I mean, we can come up with some hypotheses, but if there was some theory-based reason why they expected to find a difference here, it would make it much easier for us to make sense out of this kind of a finding without just having to simply speculate.
And William Defoe, did you have a comment?
Oh, well, article.
All right.
Can you hear me?
Yes, go ahead.
Yeah, that it may be a defensive mechanism for the physicians too. That if they don't get a sense that they really know the younger or older patients as well, it may be easier to underrate yourself so that you're not disappointed if you get some negative reactions or assessments.
Yeah.
But you're right. I mean, you have to kind of look at the whole context and what are all the different elements.
Yep. That's a very good observation. In fact, that's one of the hypotheses about why physicians consistently underrate themselves, at least the majority do. It's precisely for that reason. Jim, can we skip forward 2 slides to number 21? Okay, so looking at those results, what I really want to focus on now is the relationship between performance and self-other agreement. And I had to go outside of the healthcare literature to do that. This is a topic that's gotten a lot of attention in the business and organization literature. I was unable to find anything in our own literature. So this was a review, a study of managers in a leadership development program. So these were sort of the typical 360 in that setting with self, peer, and subordinate ratings of effectiveness. And then the supervisors were asked to use a different tool to rate the manager's effectiveness. So that was the outcome measure that was of interest. Next slide. Now, these are some of the findings. So self and other ratings, when they were in agreement and high, then effectiveness seemed to be, so when everybody agreed that the manager rated high, effectiveness seemed to be very consistent with that. However, at the other end, self-ratings that were highly underestimated, where there was a huge gap between other ratings and self-ratings, also tended to be very high. Effectiveness was lower when self and other agreement, other ratings were in agreement and low, which would make sense. But also when self-ratings were higher than other ratings, and this was most pronounced at the lower rating level. So this is when managers were overrating themselves, that was associated with reduced performance. So that was very consistent with what we know in terms of physicians, for example. So next slide, Jim. I think where where things get really interesting is in this follow-up to that particular study. In fact, Atwood was one of the authors on the second study. What this study noted is that it depends on what kind of an outcome you're looking at. So this was a multi-source feedback study of managers, similar to leadership development, may have even been the same program. Underraters had higher performance than overraters, so that same general pattern. However, when you looked at a different outcome, not supervisory performance or management performance, but rather compensation and occupying higher levels in the organization, overraters did better. So what this shows is that it depends, one of the factors that is relevant here is what is the outcome that you're looking at? Because the patterns can be very different, and the explanations for why these discrepancies are operating the way they are can be very different depending on what outcome you're looking at. So let me stop there and see if anybody has comments, observations, questions at this point.
I think Tom Van Hoof has a comment.
Yeah, so Kurt, I think in my mind at least, this might point out, I guess, problems that we have with incentives in our system. If people who, overrate themselves are doing better by way of compensation or being rewarded with higher positions, I think that points out the problems we have with the system and its lack of sophistication about what's most important, so anyway, that's just, I guess, just a comment.
And this is Barbara. I'd like to follow up on that. I think it also has to do with the element of self-confidence and how that is perceived, and really ties in with some of the gender literature too, in terms of leaning in and so forth, that people who are overrating themselves are probably exuding this perception of self-confidence that, may help to, in some cases, override a lower competence.
So, very good observation. So, the point, again, is that to some extent, what this relationship between self and other assessment and discrepancy means varies depending on what type of outcome we're looking at. I want to be sure and touch on self-efficacy. Jim, can we go to the next slide? Because this is a bit of an anomaly if you buy that this is an example of self-assessment. So this is from social cognitive theory and Bandura. Self-efficacy, many of them, I'm sure, are familiar with this, but it's beliefs in one's capabilities to organize and execute the courses of action required to do certain things that produce given attainments. Next slide, Jim. So what I wanted to do is give you an example of a self-efficacy type of assessment tool. This is from clinical research. So the instructions to the person that's completing this is that the following items are tasks related to performing clinical research. Please indicate your ability to successfully perform each task. There's a rating scale of no confidence to total confidence. Now this is, the shift here has gone from, good, bad, or otherwise to level of confidence. We would like to know how confident you are that you can successfully perform these tasks. Now, next slide, Jim. So these are some of the items. Effectively edit your writing to make it logical and succinct. Cite strengths and limitations of a study based on the data, and so on. And next slide, Jim. So this is the critical question, I think. What do you think about this? Is this a self-assessment? Anybody have a view on that?
Mila?
Well, I do think it is, but it needs to be followed up with, some actual assessment, objective assessment rather, and it's part of the reflective process that could and should contribute to improvement. But I think this is definitely a starting point.
Yeah,
and to me, it's more of a reflective part of the reflection.
Mm-hmm. In total agreement there. I think the more sources of information we have about performance, usually the better. Does anyone feel strongly that this is not a form of self-assessment in the way that we've been talking about it? Well, here's the thing. Next slide, Jim. Meta-analyses, again, this comes from the business and organization literature, just because, again, to my knowledge, this similar work does not exist in our field. This meta-analysis shows that there was a significant correlation between self-efficacy and work-related performance, correlation at 0.38, which when translated into effect size is a 0.82. That's a huge effect size. If you were seeing those kinds of effect sizes for an intervention that you were doing, you should be very proud of the education that you're delivering. And in terms of looking at it differently, the performance increase works out to be 28%. Now, to put this in perspective, this is larger than goal setting as an intervention, feedback interventions, and these are the the performance increases for organization behavior modification. Next slide, Jim. There's some support for this in the medical literature. So this is a study done by Amontorp et al. On self-efficacy with med students, their perceived self-efficacy of communication skills. And they were interested in how that correlated with the evaluations of simulated patients and observers. So this was in an assessment kind of setting. Now, students scored their communication skills lower than standardized patients, so there were 12 different dimensions. But those differences were driven by only 2 of the 12 items. They were very consistent on the other 10. So this is some evidence that self-efficacy may also have a relationship to performance ratings of self-efficacy. Sorry, my screen just popped asleep again. Next slide, Jim.
Yeah, I think Mary has a comment. Mary Turco?
Yeah.
Kurt, I just have a quick comment, thought about comparing the business literature or the business information you just showed in an earlier slide and thinking about how business students, for example, or people who attend an executive education program in a business school are educated in terms of increasing their self-confidence and personal uplift as opposed to medical students, for example. It's a very different model. And I say that having had a child go through it and witnessing it closely, it's so different from medical students, as you know. So anyway, I just want to throw it out as a comment, which may have more to do with how we think about how we're going to change how we educate medical students.
Yeah. Thank you very much for that comment, Mary, because I had intended to emphasize as I went through those business examples that we can only extrapolate so far and probably not very far, but it is provocative. It suggests that the picture may be more complex than we think it is, but it certainly warrants more research in our own area. So to sum up, going back to the questions that I posed at the beginning, are physicians really so bad at self-assessment? I think as a general rule, what this is telling me is that they're not consistently accurate at self-assessing. It's not a trait. They're better at self-assessing on some matters than others. If it involves human perceptions, so comparing rater to rater head-to-head on perceptions, it's even more problematic. Next slide, Jim.
And I think we're about at the end of our time, but Jack Dolcourt, did you have a quick comment before Kurt finishes up?
Well, I did. In terms of taking this self-efficacy concept and then looking at the question that Bob had raised earlier about, in essence, what is the gold standard? And it seems like the assessments we've been talking about are used for forcing conformity. And in certain areas that's probably important, like reducing the variability in patient care. But the flip side is that it decreases the amount of innovation. So I'm really coming around and saying maybe what we really need to be doing is having coaching. And this is how you bring out the best in high-performance athletes, so maybe high-performance physicians ought to be following that same model rather than the more pedagogical model of, setting down some standards and saying, okay, the variation from you is such a standard, therefore your grade is a B, but if you want to get an A, here's what you need to do. So my question is, maybe there's a different way that we should be trying to improve performance, and it's not really based on self-assessment at all.
Right. So thank you very much for that very trenchant comment. Let me just address, I feel like having put this question up on the screen, I need to address it. Next slide, Jim. In terms of if it matters, next slide. The self-other agreement is likely to be linked to effectiveness and performance, but not in any simple or direct way. And some people have argued that that others' assessments are really the best picture for performance, but what the research is showing, at least to this point, some of it coming from the business world, is that it's really both. No one has the corner on accurate assessment of performance in terms of rating. So thank you, everyone, for your participation in this. I'm really grateful for everyone who chimed in and contributed. I hope this was thought-provoking and interesting. Certainly Weston and I really enjoyed preparing for this session and doing it. So thank you all.
Thank you so much, Kurt. That was really, really terrific. I think we all got a lot out of it. And Mila, did you have some final comments?
I do want to thank both of you. Kurt, I think you did a great job, and will leave us pondering on these questions, I believe, and wondering, for me, for example, what I'm taking away is how can we use self-assessment more in the sense of teaching folks in medicine, maybe starting with students, how to use self-directed assessment and in a positive way to drive changes in performance, as well as self-efficacy and the feeling of having the freedom to be effective in your job and satisfied with it. I do want to remind everybody, first of all, to thank you. We have gotten a few questions along the way on the listserv. People were wondering how to join in. So remember that you do have to register ahead of time. And if you've missed anything or joined in late or missed a session, I do want to remind you that we do have recordings of these Journal Club sessions available on the website. They are in the member section, so you have to be registered as a member on the website in order to access it. And we do have a discussion thread going on, so the time is limited here, but I think this is one of those topics that obviously there's literature that many of us can cite to contribute to the continued discussion, and I would like to invite you all to do that. So again, thank you, Kurt. Great stuff. And have a great day.
Thank you, everyone.